Dr. Melissa Simon will be joining us shortly. So first of all, thank you for joining our Black Maternal Health Crisis Series, co-hosted by Northwestern Center for Health Equity Transformation and the DuSable Museum of African American History in collaboration with the Congressional Caucus on Black Women and Girls. I'd like to start by welcoming Perry Ermer, president of the DuSable Museum, who will say a quick word.
Wonderful. Thank you so much, Sam. And thanks everyone for joining us today, and especially to our participants in this important policy discussion. The DuSable Museum of African American History, as many of you know, is the oldest independent Black museum in the nation, and we are a Smithsonian Institution affiliate since 2016. We're actually celebrating our 60th anniversary this year. And although we, like the other museums and many organizations, have been closed during the pandemic, we are looking forward to an exciting reopening on Juneteenth, which this year is, which is Saturday, June 19th. So we hope that you will all join us either for the reopening celebration on the 19th, or after that point when you can come back and visit the DuSable and take in all of our beautiful exhibitions and programs in person. And of course, we'll be adhering to all public health advisories at that time. It's a great honor for us to be partnered with the Center for Health Equity Transformation and of course the Congressional Caucus on Black Women and Girls. The subject matter that we're going to visit today is of critical importance, as we all know, and it is one of our missions to really be addressing, as a matter of community education, these issues that so deeply affect the Black community and Black women in particular. So with that, I'm going to turn it back to Sam. And again, I really appreciate our participants, and I appreciate all of our viewers today for joining us. Thank you.
Thank you so much, Perry. So yesterday we celebrated Mother's Day, but we can't forget that being a mother is more than just family planning and reproductive health. It includes birth justice, an upstream trauma-informed framework that calls for collective action to build intersectional solutions that address the disparate maternal morbidity and mortality gap that exists for Black women. The growing effects of systemic disparities on Black women's bodies, such as a disproportionate amount of Black women dying from preventable postpartum morbidities, makes birth justice even more critical today. This two-part series reflects on the systemic barriers that exist in maternal health care and public policy, as well as actionable steps we can take to address those barriers. This conversation will be moderated by Dr. Melissa Simon, OBGYN and founder and director of the Center for Health Equity Transformation. Unfortunately, her computer crashed, so she will be rejoining us shortly, and therefore I will be doing the introduction. I'm Samantha Alanis, the Strategic Operations Director of our center, and this panel is called The Impact of Medical Racism. We're joined today by an amazing group of maternal health care experts, including Dr. Suzette McKinney, Principal and Director of Life Sciences at Sterling Bay, Christina Urbina, Director of Maternal Child Health Programs at Cook County Health, Dr. Bronson Tucker Edmonds, Associate Professor of Obstetrics and Gynecology, Vice Chair for Faculty Development and Diversity of the Department of Obstetrics and Gynecology, Assistant Dean for Diversity Affairs at Indiana University School of Medicine, and Carmen Green, MPH, National Vice President of Research and Strategy at the National Birth Equity Collaborative. And thank you so much for joining us. And without further ado, let's dive right into our discussion. And until Melissa is able to join, I will start with the questions, and then we can pass it on to her. So I'd like to start with you, Dr. Tucker Edmonds. Could you tell us what are the direct and indirect impacts of medical racism, and how has it evolved?
Sure, thank you. It's really a pleasure to be here, and nice to make all of your acquaintances. This is sort of a big one, so I'm going to try to give a succinct answer. I know we have lots of experts here, but I feel like you can't start the conversation without, in sort of an ahistorical vacuum. You really do have to attend to the real kind of roots and origins. And I actually think it's a conversation that starts with regards to kind of how race science, or some people call it scientific racism, kind of began really alongside as a justification of sorts, kind of that ran alongside with sort of creating the racial classifications, these systems of difference and disparity, and that was really utilized to justify and undergird a system of like white superiority. And since we're talking about Black maternal health here, sort of Black inferiority. And if you look back, I just recently read a text called Superior. And if you really look back at the ways that they that has traveled throughout the history of that medicine has been used and sort of colonized in some regards to support and undergird this sort of mythical notion of inferiority and even of kind of dehumanization, frankly, that then the rest of it sort of travels with that. Because once you sort of put out there this speculation or even actually create a whole science to try to justify and explain, that maybe Black folks are like subhuman or, kind of a different species or not entirely evolved. I mean, all of this has threads that are real and true in terms of how like scientific racism evolved. Once you put that out there, then as you move forward along the timeline and you see sort of the ways that that Black folks and Black bodies have been utilized in terms of experimentation and sort of been exploited to advance, medical science. If you look at our own birth story as an OBGYN, and looking at, the father of modern gynecology, Sims, and those experiments and the ways that our own profession is really has its roots in this sort of dehumanization and exploitation of Black bodies, like, then you have to kind of contend with that. And you start to see how that has sort of been really layered in terms of like the foundation of the enterprise that we find ourselves, practicing in and in many regards trying to dismantle. And so I don't want to just stay in that historical moment. If we fast forward and try to bring ourselves kind of up through more modern moments, we see how eugenics, we talk about the evolution of things. We understand how eugenics played into that. We understand how much of the even the present day, a lot of the real focus, the resources that are devoted to looking for like the genetic, the gene that's going to explain the difference for like everything, even though we keep finding more and more evidence that actually that gene doesn't exist and that there's more variation within racial groups than between them. But despite that, we continue to see NIH dollars funneled into those efforts. We revitalized it with personalized medicine efforts. We're going to find, the way to unlock things at that level. So I think that it's something that reinvents itself. That's actually the craftiness and the danger, frankly, of how sort of scientific racism operates, is that it finds new ways to insert itself into sort of the dialogue and into the practice of medicine and the development of science. And so, it's stealthy and dangerous for that reason. So I'll leave it there because I'm sure other people have thoughts, but that's where I think you have to start with that history and understand how those threads have continued to be carried through into our present day practice.
Thank you for that in-depth response about the historical context. Christina, why is it important for the medical community to focus on improving Black maternal health versus maternal health for all?
Great. Yes. Hi, good afternoon. Thank you for the question. And I am humbled and honored to be here in this panel with all of these very accomplished women. I am with Cook County Health, and the data, the numbers, the outcomes, right? It's really pointing to the focus that's needed on Black maternal child health. Too many Black women are dying in pregnancy and childbirth. We know the data. There are 3 to 4 times more likely to experience pregnancy-related deaths than non-Black women. Black women are more likely to experience preventable maternal child death compared to non-Black women. Their risk of pregnancy-related death spans across education and income levels. It is not, just focused on, those that don't have the access. Black women, experience more maternal health complications than non-Black women, such as diabetes, hypertension, fibroids. Black women display, or they experience physical weathering. That's something that Dr. Tucker Edmonds just kind of talked about, in her opening is, their bodies age faster than non-Black women just due to exposure of stress, chronic stress, due to, socioeconomic disadvantages potentially, or potential discrimination over the life course, thus creating, the complications, access to healthcare, access to reproductive health. So these are, just very high level reasons why it is important for us to be focusing on this, hence all of the data as well.
Thank you, Christina. Dr. McKinney, what more can medical institutions do to target bias and racism within their organizations?
Hi, Samantha, and thank you so much for the question. And also thank you all for having me today. So I think the first thing for medical institutions would be to both recognize and acknowledge that bias and racism actually do exist within their institutions. I think when you look at medical institutions from top to bottom, there are some that recognize and acknowledge that it exists and that instances of structural racism actually do occur at the patient level. But I don't think that widespread acknowledgement and recognition exists in medical institutions. So that's the first thing. I would say, of course, I believe that medical institutions should do, their implicit bias training and things of that sort. I also think that there should be training around not just diversity, equity, and inclusion, but what my good friend Connie Lindsay calls JEDI, and that is justice, equity, diversity, and inclusion. And then finally, I think medical institutions should augment this training with case studies that highlight real life examples from within their own institutions where women and minorities have experienced instances of racism. I often recall a time myself where I experienced an issue of racism in the very medical district that I oversaw, and the physician didn't know who I was and didn't correct his behavior until I helped him understand who he was actually talking to, and that it wasn't someone that he could essentially bully or make feel bad because my skin was a different color than his. So those are just some of the things that I consider to be critically important for medical institutions to do in terms of beginning to conquer the issue of racism within their institutions.
Thank you for that, Dr. McKinney. Carmen, how can we better inform healthcare workers or providers to consider breastfeeding challenges for non-traditional mothers, such as non-binary or trans mothers, or mothers who have other challenges, such as an inability to lactate?
Thank you, Samantha. Also want to express some gratitude for being on this panel today. It's an awesome opportunity. And speaking of non-traditional mothers, happy Mother's Day to all of us who have carried children who are not living on earth, or who have not, who are not born alive, because you're also mothers. But I want to lift up 3 different things with that question on breastfeeding. One is the healthcare workforce itself, then cultural and popular messaging and its impact on behavior, and then respectful maternity care for all those who do not look or lactate like normal. So with the workforce, it's like all birthing facilities have someone there who is designated to assist with breastfeeding. So even those people are tiered. They're in a hierarchy, they're trained differently. And whoever's there in that position, they're stretched. There's a lot of desire for racial concordance with that. It's important for some mamas to see someone who looks like their sister or cousin or friend to help them along that path. But just by numbers wise, it's often not available and just not going to happen. So, for example, in Louisiana, which is where NBEC is founded in New Orleans, as of 2019, there were less than 5 Black internationally board certified lactation consultants across the state. So that means Black birthing people who were looking for that experience will not get it. So the leader of NOLA Baby Cafe there was able to raise money to um, get more lactation consultants certified with their IBCLCs. They got some funding to have, recently graduated high school students do their lactation consultant certification so that they can enter into a clinical career and make some money. So, like policy wise, that shouldn't be all on a community based organization to build the workforce. With media, I'm a sociology girl, so I love talking and thinking about how media helps shape the behavior of cultures. And breastfeeding is so basic to life, but it's medical racism that has turned it and manipulated it into something that's either a social standard for some to opt into or a moral standard where you can be policed or penalized if you opt out. So for Black mamas who want to breastfeed, there are times where the systems are incentivized and funded to, go ahead and give that formula sample pack, but they may not have enough breast pumps to give to everyone. Or the nurses have taken the baby for an extended amount of time to do testing and everything, and they inform mama, oh, we already gave them a bottle, when that may not be what she wanted. So these are all internal policies for the systems to figure out. And thirdly is respectful maternity care for all the non-traditional mamas who are maybe trans, non-binary, or non-gender conforming, gender non-conforming, excuse me. So we have a culture that is not of respect. A lot of Black mamas come into our birthing experiences and, have our guard up. That's not a response to a respectful culture. And so we're trying to build that at NBEC with funding from Robert Wood Johnson Foundation, their Transforming Health and Healthcare grant. But we're trying to create a mechanism for understanding Black mamas' experiences of respect and disrespect, and then use it for quality improvement, because all hospitals have to do quality improvement. That's part of their funding and like the things that keep them going. So that's a policy thing. We're being mentored by Dr. Karen Scott, who is doing a similar um, quality improvement initiative called Sacred Birth. But with all of these like brand new quality improvement things that are coming into systems, we want to help usher through this new culture where everyone expects a, appropriate response, and they expect communication, and they expect certain things when they come in, except having to enter into motherhood with their guard up. So all of those things are really weighing into the culture of breastfeeding and medical racism.
Thank you so much, Carmen. Dr. McKinney, how much of a role does structural racism play in exacerbating Black maternal health disparities compared to social inequities like income, education, and access to health care?
Thanks for the question, Samantha. I think structural racism plays a critical role. At the end of the day, when a Black mother goes in to see her healthcare provider and experiences some form of racism, it's really discouraging. It discourages that mother from accessing healthcare. If you think about it, Black mothers have so many competing priorities. Oftentimes, we're taking care of children, we're taking care of parents, we are trying to earn an income so that our families can remain stable. We're trying to be good friends and good neighbors and so many other things. So I think when a woman goes in to see her healthcare provider and that provider is dismissive to her or talks down to her or perhaps talks up and over her head as though she won't understand what he or she is saying, that's just something that that woman, that mother is going to say, you know what, I really don't need this. And she will turn her attention away and go to address other priorities in her life. And so I think that's why it's so important that healthcare institutions recognize and acknowledge that structural racism, even within their own organizations, as wonderful as we believe our organizations are, those things do exist from person to person. So I think it plays a critical role.
Thank you, Dr. McKinney. Dr. Tucker Edmonds, how has COVID-19 worsened racial disparities in maternal health outcomes?
I don't know that we have the full, we don't have the vantage point yet to know the full impact that it's going to have or what it's meant. But I do know that there are clear concerns about what it's meant for sexual and reproductive health more broadly. I think the verdict is still out on the ways that telehealth, though it has been, in some regards, feels like a godsend in the midst of the pandemic. It also has real potential shortcomings and shortfalls with regards to populations that that may not be able to kind of as readily access telehealth. We think there's still a lot of questions about what it means for rural populations and urban populations for different reasons. And so, I don't know that it's the godsend yet, but I think there's still lots of work to be done to really try to understand what that means in terms of access. I think the other thing that there was fairly kind of robust conversation about early on that is particularly concerning with regards to the experience of obstetric racism and sort of obstetric violence that Black women have been subjected to historically, were the visitation restrictions with regards to labor and deliveries and sort of birth, their birth and delivery experiences, and maybe or not maybe. In fact, there was a lot of debate early on about labor support, whether doulas could be present, what it means to kind of really have it pared down. So kind of just maybe your partner, maybe your mom. But I think when you already are sort of has been mentioned by Ms. Green, when you are already entering a health system from a posture of threat and anxiety and fear of harm, then this issue about being sort of further stripped down in terms of the folks that you have present to advocate for you and potentially kind of serve as a means of kind of protection. I think that there was a lot more fear and anxiety in that space. Now, what that means in terms of how that's translated to real, let me be careful, not real harms, to medical harms or adverse outcomes, because that anxiety and fear, I believe, is a harm in and of itself. But what that means in terms of obstetrical outcomes, I don't know, again, that we have the benefit of kind of the historical vantage point or a lot of analysis to really understand what that's meant. But I think that those are things that we should be paying attention to and concerned about with regards to the impact that it's had. There was also a large conversation about whether to kind of divest from hospital-based care. And I think that because of some of the embodied realities of disproportionate morbidity and mortality that Black women bear because of, who mentioned earlier, Dr. Abina, I believe, the chronic stress, the weathering impact, the impacts of structural racism, I think we have to really be looking for more integrated responses, not either or, but kind of both and responses, so that we can support women with woman-centered care, midwifery models, labor support, and the medical kinds of support that are needed when you carry disproportionate burdens of hypertensive disease, just mental health and wellness concerns. I mean, a whole host of things that actually come with embodied oppression. And so I do, again, as I think about sort of a research agenda moving forward, those are the kinds of things that I really am concerned about in terms of the impact of COVID.
Thank you, Dr. Tucker Edmonds. I gave birth in August of this past year, so that wraparound stuff sounds fantastic, and I hope that we can make that happen. Dr. McKinney, how could diversifying the workforce potentially improve maternal health?
Well, I think it goes without saying that representation matters. When providers come from the same communities that their patients come from, I believe that there is a level of comfort that exists automatically, especially on the part of the patient. And as long as the provider doesn't do anything to essentially take away that level of comfort, I think patients are more at ease and perhaps feel like, they're understood even before they get too deeply into the actual visit and the reason for that visit on that particular day. I think also, as we saw with COVID, and I think providers in particular have seen time and time again just in their practice, when that provider is able to understand inherently all of the pressures and the challenges and the other things that their patients have to deal with separate and aside from healthcare, it gives them a bit of a different lens, I believe, through which they provide care. And oftentimes they are able to say, okay, well, since you've expressed that you're experiencing this issue, perhaps can I suggest this type of wraparound service? Or, they may suggest certain types of wraparound services or other resources just because they understand those pressures and where the patient is coming from. Now, I would be remiss if I didn't talk, though, about just some of the extreme challenges that we see among African Americans and people from other underrepresented minority groups, just trying to get through the medical school and medical training pipeline so that they can actually become healthcare providers. I think that there are so many challenges that we don't address. You can have two students go to the same college, go to the same medical school, have access to the exact same professors, and even get the same grades. But when you start looking at money that is available to purchase textbooks and application fees for residency and traveling around the country for interviews and things of that sort, the social and income and economic inequalities that exist, just that are inherent in our society, are compounding factors, I believe, that sort of restrict the healthcare workforce in terms of Blacks and other underrepresented minorities.
Thank you, Dr. McKinney. And before I move on to my next question, I want to encourage our audience, if you have a question, please use the Q&A function in Zoom. And also, before we get to the end, I want to recommend to the panelists to think about if you have specific resources that you would like to recommend at the end of this panel. So I'll make sure to ask that again once we get through all of the questions. So please let us know and feel free to also add it to the chat. So moving on, Carmen, as we consider current and historical trauma associated with Black womanhood, how do we increase self-agency among Black mothers to support their ability to take control of their health and be advocates for themselves?
Thank you, Samantha. So Dr. Tucker Evans mentioned it earlier, but the embodied impact of like past trauma or disrespect and racial microaggressions, even in the moment, like we cannot ignore the impact of it, but it's both and. I think that as far as self-agency and taking control, Black birthing people, we're doing our thing. All mamas are doing their thing. They know self-efficacy. They're advocating for themselves each day out of the love they have for their families. And that love just turns into strength. Mamas have supernatural strength. That's when you see them lifting cars, but it's also like exerting energy to change your provider or to like really stand strong in denying or refusing a medical intervention when you have 5 providers telling you something different. You've all seen that, and that's a lot of strength and control, but I think it's unfair to ask one like very physically vulnerable, laboring human to stand against a system that wants to take control of the experience. I don't think it's fair. And I don't think it's culturally appropriate. In so many other places around the world, we are not asking mamas to be their own soldiers. And we have to do that in this moment. But I hope there's a time in the future, in the near future, where we're not having to put the onus on a birthing person to be their own strength in that moment. But that's a lot of what doulas do. So I'm a doula, and I believe that every birthing person deserves a birth attendant like that, or a midwife or a OBGYN that was trained with holistic means to help balance that energy of who is in control. Like in my doula training, I learned that the mama's in control, but that human that's coming earthside is really in control. And to, help set up that true hierarchy again. So doulas teach mamas the inflection points in the labor process where unnecessary interventions might come. We're teaching mamas key words and like little tactics, tips, and tricks to slow down a nurse who might be bringing those episiotomy scissors really quickly. We're trying to really intervene in these key points. And doulas are doing that because, if we're present, we can serve in that purpose, but it's the mama and her partner or her sister or whoever is their support team to know all of those things. So I say a way to continue increasing agency is to make space and funding for more doulas to be an active part of the care team.
Thank you so much, Carmen. Christina, how do we train healthcare providers to provide patient care that is free from bias and unequal treatment for Black mothers?
That's a big question. And I don't think I alone have the answer. And thank you, Dr. Tucker Edmonds. I'm not a doctor, I'm an operational person, but I appreciate, the confidence in me in that way. But that is a big question. And there's not a silver bullet answer to that, right? But it's a multi-pronged approach. And I think Dr. McKinney actually kind of laid it out beautifully earlier in her response. It has to be, a valued pillar of an organization, an educational institution that is training these medical providers, not even just the doctors itself, the clinicians, the nurses, the medical assistants, the CNAs, the ultrasound techs, like anybody who has patient contact, anybody who is interacting with that bedside manner with mom, with family. It definitely has to be a value and it has to be a focus. And all of the tangible components of, trauma-informed care needs to be part of the curriculum. Culture, I'm a big fan of cultural humility. I don't think we can all be culturally competent, on all the different cultures that we're interacting with, but if we can interact with, each mom with humility, I think that goes a long way. We have to, again, be aware of the microaggressions, that we all have biases. But if we can realize and own what all of those are in each of us, and the providers can do the same, and the patient care team, I'm very proud to work for an institution that all of these components, the teaching components, are part of a training track. Can we do more? Does it mean we could check the box to say, we're doing the right thing and we've got the magic formula? No, but we're part of the solution. It is really, a part of the focus of this institution. We are a county hospital, and, Ms. Green mentioned, the experience starts the minute the patient walks through the door, the minute the mom walks through the door, with partner, with kids, with family members. And, it's not just the provider interacting with mom, it is the security guard, it's the person registering mom, it's, the nurse or the MA doing the intake. All of this is part of the experience that really influences and engages, with moms to adhere to care, to want to come back, to feel comfortable, to feel they're in a safe space. right? To take all of the outside worries away that they're coming in for their own healthcare. It all matters. So what can we do to train medical providers? I think it's, that's, yes, there are all of these different things that we've all talked about, but we also, I would be remiss to leave out any of the patient care team, right? Because providers don't do this alone. And this is a community, right? It's a community inside the medical institutions, out in our communities. I work for a health system. We've got hospitals and we have community health centers. So I can see both sides of it. And programs to support. Miss Green, I'm also a sociologist. So, I think broad, I think, how can we link arms? Part of my lens here, and I'm trying to think, how can I add value, to all of this expertise here, and how can we help support improving outcomes? We do need the programs, the family planning, the WIC, home visiting services, like the HRSA Healthy Start, where, we have a HRSA Healthy Start. We have intense home visiting for parenting and child development. So not just during prenatal care, but after birth, right? We need to check in on the moms after birth to support outcomes. All of the child visits and postpartum screens up to a year. We have an initiative here at Cook County Health called Silent Cries, where part of the child visits, we're doing screens for moms to make sure mom's okay, right? So it's a lot of, I just think, thank you, Ms. McKinney, for answering earlier, but I just wanted to add value to just say that, yes, all of the components on becoming self-aware, any clinician becoming self-aware to engage in partnership with somebody coming for medical care is important, but it also is important for the organization to find that same value in all of the support staff and equity in the workforce.
Thank you for that, Christina. Dr. Tucker Edmonds, the Journal of the American Medical Association, or JAMA, recently got in some hot water over a podcast and tweet in which they question whether systemic racism is real. And academic journals have been called out for refusing to keep the word racism in many of the manuscripts that are submitted for publication. What can attendees do to galvanize change in academic medicine so that racism and the harms it has caused are recognized and addressed?
Yeah, it's a big question. I guess you've had a lot of big questions, so I'll take a stab at it and start where I can. My sort of really fundamental belief, we talk a lot about like changing the climate and making inclusive climates and things like that. And I think that climate and culture are changed from the top down. And that there isn't real power from the ground up, because what we are seeing is unprecedented in terms of the demands that students and learners and trainees are making on health, on academic medical systems. So please, let's not discount the importance of that work and that effort. But I think when you're talking about culture, climate, oftentimes that's based on structure, that's based on policy, that's based on practice, and that's based on leadership and what's modeled and what's accepted and where the accountability falls and doesn't fall. So for me, if we're going to ask a question about how are we going to sort of change academic medicine, then I think we are having a conversation about the leadership of academic medicine and about their level of commitment and accountability and courage, frankly, with regards to leading against the grain, being, and centering these issues of equity more so than kind of other pressures that are real, that would encourage them to not be too out front or too outspoken with regards, taking a strong like anti-racist claim. And you've seen substantial variation in terms of medical school and their leaderships, in terms of how folks have been willing to come out, making specifically like anti-racist claims, statements, et cetera. I also think that statements aren't enough, but I think that statements are a start. And then it comes to, and what other actions, what other changes, like I said, what other, what else is going to move with regards to your policies, your practices, and accountability. The other thing that I'll say, and then I'll open, I'm sure other people probably also have thoughts about this, is that what feels more practical. So sometimes people hear that and it's like, oh, you're supposed to like take an equity lens to the policies, and people are like, what are we talking about? How do you do that? But I think another space where there is very real and tangible work to be done is around curricular reform, because that does have implications for the future. And we are, the first question you asked me spoke to these issues around medical racism, and it's really embedded in our curricular content. It's embedded in the ways that we develop cases. Students are trained to identify patterns, and it's pattern recognition until you actually develop some competence. and those patterns are kind of, very much sort of based in like stereotype or sort of limited kind of narrow perspectives on sort of the full like human experience. It shouldn't be that every time, it's a young Black child must be the sickle cell, in pain, must be the sickle cell case, a gay man with rash must be, we learn these patterns, and that begins to diminish and narrow our picture of who the full patient is that's in front of us. A gay man should be able to come in and have a toothache and then not have anything to do with HIV. Like we should be able to take care of Latino men and then not have anything to do with machismo or IPV. These stereotypes are deeply embedded in the kinds of cases that we construct, the kinds of patterns that we reify in the ways that we educate our learners. And so it is like time out for that. We have to immediately address the ways that we have sort of designed curricula that propagate very much stereotyped notions of who people are. And that's why my first answer came down to this notion of dehumanization. I've just been giving a lot of thought about the work that we have to do to elevate and to like create 3D depictions and notions of who the patients are in front of us. They are not 2D, subjects to be interacting with. So I could say a lot more. I'm going to stop there because I know where we are with time, but those are my early thoughts.
Okay, thank you for all those ideas. So I have a couple of final questions for all the panelists, and I will just go through you one by one based on how you appear on my screen. And it's a two-part question. So the goal of both of these panels that we're hosting today and Wednesday is that we can all walk away with some action items and make sure that we know how to actually move forward from here, what are actions we can take. So for each of you, I'm asking what needs to be done at the policy level to create an anti-racist and accessible healthcare system that will address Black maternal health disparities? So that's question one. And question two is, do you have any recommendations of resources for our attendees to check out? And I will start with Carmen.
All right. So thank you for that question and the opportunity to share resources. I'll answer the second question first, which is our first kind of big blast publication about respectful maternity care was just recently published. It's in the International Journal of Environmental Research and Public Health. It's at open access, and we intend to continue down that path to create quality improvement resources, including an experience measure. So that is there. And if I could, before we get off, I'll put the link in the chat. To answer the first question, policy-wise though, is that we at NBEC and a big group of almost 100 other community-based organizations and associations, we're advocating for an Office of Sexual and Reproductive Wellness in the White House, in the Biden administration. And so this office would work in tandem with the Office of Gender Equity, but it would do more because we wouldn't be limited to talking about gendered politics of economic inequalities and workplace policies. That office will allow us to open the conversation more about bodily autonomy and our rights as a community to raise children in safe and sustainable communities. So this is what we want to see, us talking about reproductive wellness in the White House level. And maybe they can help us push some things like the Momnibus bill and things that are really critical to Black maternal health in policy. That's what I'm saying. Thank you.
Thank you, Carmen. And I'm glad you brought up the omnibus because we'll be talking about that on Wednesday and hope that attendees will register to join us for that conversation as well. Dr. Tucker Edmonds, could you answer next?
Oh goodness, where to start? I think that, well, I was thinking about it in the academic space, just because I think I'm kind of bring that unique perspective. There are folks in other spaces. So I'll say to that there has to be a new, the currency of academic medicine is papers and grants. Period. And that is the reality. Now, that's not an objective standard or enterprise, but it is what it is. And if we're going to make room or real commitments for sort of equity, diversity, so, you know, the JEDI kind of agenda, then we have to adjust our policies around like promotion, our reward systems, what we incentivize to actually center that work, as opposed to that being kind of marginal or like fringe work that maybe some minoritized folks or some women kind of contribute their time to in their free time or without support. I think that there's work to be done in academic spaces about saying, like, how do we build this into our promotion and tenure process, even to the point of the questions that have been had about, you know, leaky pipelines, or maybe I saw that in one of the chats, you know, like how do we get people to advance and be able to move into leadership that are from historically marginalized backgrounds. I think some of that is the way that we've set up our reward systems. And the other things that I think are needed are sort of kind of more enforcement and accountability in terms of like, what does it mean to take an anti-racist stance? How do we deal with that in the face of kind of a lot of scrutiny around free speech, and, you know, kind of how do we maintain both a safe, psychologically safe environment for learners to be in, and not sort of, you know, keep bumping up against this notion of like, you know, free speech at the expense of other people's psychological safety. I think that that's an important set of concerns to contend with in the space of learners and trainees. Yeah, I will stop there because this feels like I could go on, and there are lots of other brilliant people who would like to who I think we could learn from. So I'll stop there unless I think of something super important. I was going to put that book that I mentioned in the first answer that's called Superior. It's by Angela Sinai. I'm going to put it in the text. It's not so much a resource, but I was invited to be an expert on a panelist somewhere, and they were reading this book. And it's, I think everyone in medicine and everyone in science should actually read it to really understand scientific racism and its pervasiveness and its persistence. And I think we have to contend with that and understand what really undergirds the enterprise that we're in if we're going to figure out how to, I'm going to use the word dismantle and make people upset, but if we're going to figure out how to construct it anew in a way that can serve everyone. Because the system's not broken. It was built like this. It was built for this. And so we have to do it differently if we're going to get better outcomes for everyone.
Thank you, Tucker Edmonds. I love that. Dr. McKinney?
Sure. So you asked about policy, and I find I frequently have thoughts about policy. So I think the first thing I would say, just with regards to what could be done, or conversation that could be started at the policy level about anti-racist, creating an anti-racist healthcare system. I think that, you know, the federal government and the accrediting bodies need to get together and create some policy. I believe that, you know, policies could be designed to help remove barriers that exist, first and foremost, to the ability to diversify the workforce. I think that's probably one of the early things that can be done from a policy perspective. I also think that our federal government could be a little bit more proactive in that process, and perhaps provide incentives to institutions that aggressively work to decrease barriers to diversifying the workforce. And then I think specific to anti-racist behavior, and I wrote this down because I didn't want to forget it, but I think that structures can be developed and implemented for patients to be able to express their concerns and express specific examples of racist behavior that they've received in healthcare, you know, and even express their complaints. But to be fair and to ensure that patients don't experience retaliatory behavior from the institution, I think that these are structures that could be monitored and enforced by the licensing bodies. Because of course we want to encourage and support patients to reporting this type of behavior, but at the same time, we need to protect patients so that they don't receive any type of retaliation as a result of doing so. So those are just some thoughts that I have around what can be done at the policy level. You threw me off a little bit about the resources question, but one resource that I thought about very quickly, because I'm always thinking about this issue around diversifying the workforce. Dr. Stephen Martin, who ironically used to be the Chief Operating Officer of the Cook County Department of Public Health, now runs a nonprofit organization called the CPAS Foundation. And they are specifically designed to introduce traditionally underrepresented minorities, middle school and high school children, and college students to STEM careers. And they also have a specific focus on growing the pipeline of Black male physicians. And, they partner with medical schools, they partner with hospitals and other educational institutions and healthcare institutions to provide real life exposure and experiences to these young people. But I would say, if you're interested in doing something really tangible to address this workforce issue, I would suggest perhaps donating to the organization or going onto the website and identifying how your institution could participate in helping expose young people from underrepresented communities to the STEM careers, and in particular, the medical field.
Thank you so much, Dr. McKinney. And finally, Christina.
Thank you. It's so many resources, and I mean, although I'm a panelist, I'm learning so much from all of you. So in terms of policy, I mean, I think most of it has been touched. I would just kind of add value or just wrap it around with just a lot of the policies that are, or some of the policies that are currently being pushed, for expanded coverage, Medicaid coverage, just policy extended for extended leave, an extension, longer leave, more funding, federal funding and resources, around, programming, that's the space I'm in, coverage for doulas, things, small tangible things like that. So just, policy to increase more federal fundings for wraparound services, supportive services. And in terms of resources, you threw me off too, but I will have to think about it and put it in the chat or follow up with that.
Okay, thank you so much. I'm sorry about throwing you off with that, but we will definitely send a follow-up email to attendees so that they can have any resources that you'd like to share afterwards. So I'm going to pass it to our faculty director, Dr. Melissa Simon, to say a quick thank you, and then we'll get into audience Q&A.
Whoa, rock stars, all of you. Thank you so much for spending time with us today, enlightening us with some really, really important framing that I couldn't agree more with, each and every point raised. And oh my goodness, I wish we had more than an hour because we could go on and on and on. I absolutely hope if you do all have time, you can join us on Wednesday at afternoon, because we are going to have a continuation of the panel with around omnibus and policy and things like that. So I'm going to open it up because we have a lot of questions, and some of them are even bigger than the ones we asked you to begin with. So, but seriously, thank you. Seriously, we really appreciate your participation on this panel today. Thank you. And thank you to all the participants. So who, Cassandra, would you like to lead the panel discussion? I'm sorry, the questions?
Sure thing. So
Thank-
I will direct the first question to Carmen. Thank you for your presence today. The first question from the audience is, how do we make doulas more accessible and also more holistic providers as well, more accessible? And what role do you think doulas and other birth workers can play in better shaping Black maternity health worldwide?
Ooh, worldwide. I like that global question. Thank you, Cassandra. To increase their accessibility is that there are several states right now. I think there are bills in 22 different states trying to increase reimbursement funding for doulas. It is on the platform for Momnibus to like increase that funding and uh, maybe help create some more favorable um, like workplace standards to make doulas feel like a welcome part of the team. But as these things are moving through state legislatures, they have some like different clauses, like all of the doulas in order to get reimbursed need to be certified by one specific body. That's harmful because always funneling it back to one accrediting body for the doulas doesn't include like like Black woman-led doula collectives. It doesn't include many of the holistic doula trainings that are out there. So when you exclude the people who are trained with the holistic frame, it kind of makes the whole policy a wash. So supporting those types of policies as they're moving through. And then what was the second part of the question?
What role do you believe doulas and other birth workers can play to better shape Black maternity health worldwide?
Okay. They can continue to play the role that they're in. The term doula is not recognized all across the world, um, uh, but its position and its like efficacy is like the birth attendant is a like worldwide construct. So I would say if more trainings are centered around a holistic frame, we are on the right track.
Okay. Thank you so much, Carmen.
Thank
My
you.
next question is directed to Dr. Tucker Edmonds. And you alluded to this in a previous question regarding galvanizing change in academic medicine. But the audience member asks, how do we evaluate, correct, and even monitor medical pedagogy in textbooks, laboratory, and at the bedside to reflect the realities of racism and its impacts?
We all have some good, difficult questions. I would suggest we were putting in the thread a little bit because the topic of licensing came up before. And I really do, I mean, as I've come to appreciate where the levers are, I think that that accreditation kind of bodies and sort of oversight kind, organizations and things really are going to have to kind of make the demand that these be attended to, that there be sort of like an answer for, or some type of assessment of these types, these kind of curricular components, or even, across the board. I mean, it comes up in all kinds of spaces, but I do think that just off the top of my head, because it's really hard, even when you're pushing uphill from diversity affairs offices or from the ground floor, as the students are pushing, it's really hard to get the attention, buy-in, and sort of pull the right levers for sort of executive level leadership, because they have so many competing interests that are coming at them, and their larger responsibility is to the organization, right? To like stay kind of afloat and accredited, and all the I's need to be dotted and the T's. And so to understand how the system works and how things become a priority, it really oftentimes is that which is sort of scrutinized, that which is required, that which is, kind kind of identified as a problem, be it through LCME or be it through AAMC or some of these other accrediting kind of bodies, that is what ends up getting attention and resources devoted toward it. So I would say that would be kind of an initial point, is that this becomes something that outside agency, JCO, LCME, like ACGME, that those levels of oversight will have to start to say that this is something that we take seriously, and that we're going to hold you accountable to these standards in order for a lot of the levers and resources to be deployed. Frankly, I think that's right now.
Thank you, Dr. Tucker Edmonds. In the interest of time, I will ask one more final question, and I will ask that Dr. McKinney answer first. So as we are talking about this issue, what should the health system focus?
Uh-oh. She froze before I heard the question.
Okay, I think I can ask it. So what should the health system focus on first, especially given that hospital leaders are paying attention right now with the heightened focus on health equity in this area?
Well, I think that hospitals should focus on their own internal policies as well as their own internal practices. What are they actively doing to create more equitable healthcare experiences? And when I say what are they actively doing, I don't mean just talking the talk about, oh, we're going to do this, we're going to do that, but actually walking the walk and establishing policies, practices, and measurable metrics. I hate to use a similar word, but having actual metrics to evaluate how well they're doing, both from a patient perspective, as well as from a provider or perhaps a staff perspective. I mean, I think that at some point, while we can and should use licensing bodies and accrediting bodies and perhaps even the federal government to hold hospitals and health systems accountable, I think, as Dr. Tucker Edmonds said earlier, leadership starts at the top. And CEOs of these hospitals and healthcare systems should care about how their patients are being treated at the provider level and should be willing to step out there and hold their own institutions accountable for their practices and their behaviors. And so with that, I do need to apologize, but I have to jump to another call. But this has been a fantastic conversation. Thank you again for having me. It was such an honor to be on today with so many other just established and phenomenal women. Thank you.
Thank you. So I will go ahead and bring us to a close. And I'd like to reiterate the importance and impact of collective action in addressing the existence of the Black maternal disparities gap and why it must encompass a birth justice framework. So the healthcare and public health community has long underestimated and in some cases ignored the correlation between systemic and structural racism and the Black woman's maternal care experience. And even as we discuss motherhood, we certainly cannot leave out non-traditional mothers whose disparities are often underrecorded for various reasons. But I want to leave you all with these words that eradicating the Black maternal health crisis must be the goal. And to do so, we must prioritize equity and elevate, trust, and support Black women and other womb-bearing persons. So I would like to thank all of our panelists and the virtual audience members, of course, for joining us this afternoon for part one of our series discussion. And if you haven't already, please register for the second part of our series, Bridging the Gaps in Health Policy, which is Wednesday, May 12th at 6 p.m., featuring Congresswoman Robin Kelly, Congresswoman Lauren Underwood, Dr. Ann Borders, who's the Executive Director and Obstetric Lead of the Illinois Perinatal Quality Collective, Shaquan Dupart, who's a doula and founder of the Chicago Black Doula Alliance. And the discussion will be moderated by Candace Moore, Chief Equity Officer at the City of Chicago. The registration link is in the chat to sign up for the discussion. Thank you all again.